So it's really neat here. I get to have a conversation with you, Dr. Jeff Zorn, because I want to just share really quickly for people listening. Like we grew up in the same tiny small town in Saskatchewan, and get to come back together to talk about, of all things, prostate cancer and the pelvic floor. So I really appreciate, Jeff, you taking the time to go through this with me for the benefit of all the listeners that are going to take the time to listen. So I appreciate this.
Yeah, no, thank you for having me.
Can you just, for the benefit of people listening, Jeff, can you just take some time to just introduce yourself, like where you're located and a little bit about yourself?
Sure. So I'm a urologist practicing in Comox, BC on Vancouver Island. Did all my medical training residency at the University of Alberta and then started working here thinking about the summer of 2014. So just over 10 years ago, goes by very fast. Yeah. And yeah, enjoyed we have primarily it's a community-based practice here. That's where we would be considered rather than sort of an academic type of thing in a bit of a smaller center. But our sort of breadth of work is still pretty large, and we capture a pretty big area, all sort of North Island and across to the Sunshine Coast, if people are familiar with that. So a fair bit of work done and a fair bit of prostate cancer stuff done here with our sort of patient demographic for sure.
Yeah, and so just to kind of set the tone for the conversation, this is going to be like a two-part episode. You and I will talk today a little bit about like prostate cancer. Like just I want people to understand the flow of like how is this diagnosed and how would you know you have prostate cancer? And then talk a little bit about the different treatment options you might be able to offer someone.
Sure.
And then in the episode that follows this, I'll talk with another physio just about some of the things that we look at specifically as physios, someone before or after their treatment. So, can you
Perfect.
just set this? I like to kind of start from the beginning for people, and just talk a little bit about like just overall prostate cancer. Like I know it's the most common cancer that affects men, but just overall, can you just explain a little bit about, just in general terms, just start talking a little bit
Sure.
about the prostate itself and how you describe that to your clients or your patients.
Yeah, so firstly with prostate cancer, as you alluded to, it's a very common male malignancy. Typically, we would sort of say, and the data obviously changes with whatever you look at, but anywhere from sort of 16 to 18% of Canadian males will get diagnosed with prostate cancer at some point in their life. So that usually sits at probably, 1 in 5 if you're looking at a kind of a round up to 20%. So the numbers, the amount of people are affected by it, of course, is not insignificant. Now, we also look at it as one of these cancers as well, that as you age as a male, it becomes much more prevalent. And in a lot of scenarios, when you get into your sort of, late 70s, 80s, prostate cancer typically is a slower moving cancer. And in a lot of cases in those scenarios, making a diagnosis of prostate cancer in an 80-plus-year-old may not ever actually impact their longevity or benefit them. But of course, in men who are anywhere from sort of 50 to 70, that is obviously a different story. Um, Typically, the prostate, it provides, its role as, it provides secretions to the male ejaculate. So, but when it comes to sort of there being issues with it as men age, their prostates do enlarge. There's a capsule around the prostate anatomically, which then sometimes when the prostate gets larger, it can create urinary symptoms. And prostate cancer in itself can do that as well. But it can be sometimes very tricky. And as you know, in your field is that urinary symptoms don't always mean that you have prostate cancer. Like the vast majority of men that we see with age-related urinary symptoms, or even in younger men, don't have prostate cancer. They have benign prostatic enlargement or some pelvic floor dysfunction that you guys see that cause these urinary symptoms. But prostate cancer, when it sort of presents symptomatically, can definitely present with urinary symptoms. Having said that, what we sort of advocate for, and the reason why screening becomes important, is that often with prostate cancer specifically, if you are getting to the point where you're getting symptoms from prostate cancer, it's oftentimes it may be in a more advanced stage, right? So when we're looking at diagnosing this, typically speaking with any sort of urologist or oncologist that deals with prostate cancer is that we would advocate strongly that people undergo sort of regular screening for that. Typically starting at the age of 50 is the usual recommendation. Although if you have risk factors, family history, stuff like that, 40, 45, 40, depending on when, a first degree relative was diagnosed. And so screening people in the asymptomatic setting, right? So that you're getting an annual, digital rectal exam or PSA. And then depending on what your numbers look like, sometimes those can be lengthened out, 2 to 4 years if your numbers are really low and there's no concerns. But, practically, we would typically say that, doing an annual PSA and digital rectal exam in the asymptomatic patient would be, the appropriate screening so that this can be captured early, right?
So as women, like around 40 is when I'll get a notification in the mail or from my doctor or whatever saying I should go for my breast exam or from my mammogram. Does like on the male side, would it be like that's what I'm wondering, like there's not the equivalent of that, correct?
Yeah, like typically it would be hard for me to totally speak from that for what is coming out from a primary care level to patients. But I would have to say that like the initial there was a little bit of a probably about, and I again have to sort of look exactly when, but about probably 10, 15 years ago, because it was coming out around when I was training, is there was a sort of a task force statement in the US, and then that kind of propagated that we weren't benefiting by screening for prostate cancer. We weren't helping people, and we were causing we were over treating people, and by screening for it versus catching it at a later when symptoms developed, it wasn't necessarily on a demographic or population basis helping people or saving lives. But what they didn't look at is this sort of the data that was looked at. That was, we know that prostate cancer in broad terms, if left undone, would probably take 10 years before it would impact someone's longevity, right? And the studies that they were looking at to make those recommendations, which were only followed out to sort of not quite the 10-year window or the 10-year window. So they weren't capturing people who had already, wouldn't have died yet anyway, right?
Right.
And so after they've relooked at that, there's been a bit of a shift back where the recommendation, on a primary care level should be that people do undergo prostate cancer screening. And we've definitely seen, as I started practice and that had been in place for, sort of 4 or 5 years or whatever it was at the time, a bit of a sort of a stage migration, meaning that we're seeing people with more advanced disease. And it has to do to the fact that they weren't being screened as regularly. And I would have to say too, even now, seeing a little bit, and this is all anecdotal, but now that after COVID, when people were just not as easy to access their family doctors on a regular basis, or as you know, in BC, there's obviously a bit of a family doctor issue in regards to people obtaining primary care physicians, that we're seeing people then who are having their PSA checked or their prostate checked once they develop symptoms in 50, 60-year-old men, which at that point they're at a much more advanced stage, when they maybe if they'd been screened, X number of years earlier, it would have been picked up, diagnosed, and treated before it had sort of maybe a negative impact on their prognosis, right? And the treatments for advanced disease have really come a long way, and we can definitely provide good disease control for longer periods of time. But these medications don't, they don't come without side effects and impact, right? And so there definitely is impact on people's quality of life with delayed diagnoses, and also cost to the system with the medications, and the fact that they do cause a lot of side effects for people. And at some point, if you're a young man and you haven't been screened and do have a prostate cancer, it will impact your longevity, right?
So basically then, like just so that people listening have an idea, so either like I think a couple things could happen if you have a family doctor. They might kind of mention like, oh, you're at a certain age, we should start looking into this. Or someone might start noticing symptoms. It sounds like mostly they could expect urinary symptoms, correct? Like, actually,
Typically, initially,
maybe touch on that while I'm on that. Like, what other things maybe would they kind of start noticing that might make them bring it up to their primary provider, like their family doctor?
yeah, so I would say like, so in the early sort of state of the game would typically be probably if you were developing issues with prostate cancer would be urinary symptoms. But realistically, early on, prostate cancer doesn't necessarily cause you any symptoms,
Hmm.
right? So it's kind of the same thing when, like you alluded to with breast cancer, where you may not have any it may not have any symptoms, you may not notice any masses, but you go and get your mammogram and something's picked up, right? So it's very similar with prostate cancer in that the idea with screening and the sort of definition of screening, of course, is doing this in somebody who's asymptomatic so that you're picking something up before it
Yeah.
actually becomes the problem. So in a lot of cases, in men who develop symptoms that are specifically from a prostate cancer, it could be that their disease is more advanced. It doesn't
Hmm.
always mean that, but it could be.
Hmm.
And then it always becomes a little bit tricky too, because like I mentioned earlier, there's a lot of people who come in with urinary symptoms who just
Totally.
have
Totally.
urinary symptoms, right? Advanced disease presents very similar. Either people will start having progressive urinary symptoms. Sometimes, when we see guys who come in who are maybe more elderly or stuff like that, it'll be more incidental that they'll come in with, developing back pain and that type of stuff. They're looked into by the family doctor, PSA is done, and then that is markedly elevated, which because we know it's very common, it's known to sort of check it. And then people will come in with, much more sort of advanced bone symptoms, and that's from metastatic disease, right?
So would you assume then that, and again, we can't speak for every primary care provider, but would you assume that the PSA, and I actually want you to explain that a little bit more to people, like what does that mean?
Okay.
What does it stand for and what are they doing? And then also like would people expect, because I think I've heard that, and please correct me if this is not true, that they're starting to do away with some of the digital rectal exams more because the PSA is more accurate. So I don't know that someone would expect always to have both done, but could you just explain a little bit about what someone might expect when they have both of those done?
Sure. So firstly, what this PSA is it's a blood test that's done, and it's what it stands for is prostate specific antigen. So it's a marker that every person or every man who still has their prostate in will have a circulating level of that in their body. Okay, and it's one of those things that is, it's looking at it is it's sensitive for picking prostate cancer. And what I mean by that is typically that if you have a prostate cancer going on in your prostate, typically your PSA is elevated. Okay. But on the flip side of the coin, it's not all that specific. So just because your PSA is up doesn't always mean that there's something bad going on in your prostate. You can have an elevated PSA. We know that increases with age. Prostate size will cause your PSA to be higher. Sometimes irritative urinary symptoms. So people come in with really bad urinary symptoms from just benign enlargement or from pelvic floor dysfunction. That can sometimes cause an impact on their prostate and their numbers. If you have urinary tract infections, the numbers go way up. So it's one of those ones that we use it, but you have to kind of use it as, with a little bit of a more sort of good look at it, right? So a one-off PSA that's elevated typically needs to be repeated to make sure that it is truly and confirmed to be up. And then ultimately sometimes too, when you look at them, it's also looking at trends, right? So if you've seen somebody who you've done, primary care physicians have done their, regular PSAs over the course of years, and they see that there's some increase to it. It's also looking at trends with it too. So that's kind of been a little bit of the backlash with doing it, is that it's at times it's not the most definitive way to say there's yay or nay something going on. But it is the only way that we at this point still screen for it. And it's pretty easy to do because it's just a lab test. But it does have to be looked at a bit nuanced, right? The digital rectal exam we would still advocate very strongly for, right? Sometimes, I think the bigger thing with it is again, during, there's been a lot more telehealth done and stuff like that, and acknowledging that, and it's not the most comfortable test for the patient. for the physician. But definitely what the digital rectal exam does is that there is a subset of prostate cancers that don't generate a lot of PSA. So if you feel a palpable abnormality on the prostate, and most of the time their PSA will be up if there's a cancer there, but not always. And so you are then still picking up some patients that have potentially a prostate cancer going on based on a palpable abnormality, versus, also, I guess, incidental sort of colorectal stuff if it's present. But that's why we would still advocate that you need both.
And so would it be fair to assume, well, in our Canadian system, that some people that have a family doctor, they could expect that if that's a conversation that comes up, whether it just be age related or symptom related, that they would order the PSA, the family doctor. Or if you don't have a family doctor and you have questions or concerns and you go to a walk-in clinic or what have you, that they would order the PSA. And that some doctors might, with an elevated PSA, refer to someone like yourself, a urologist, and maybe other family doctors would wait to see that trending. Or do you think would the urologist expect to be consulted as soon as the PSA is elevated?
Yeah, no, like what we would typically from a primary sort of standpoint of screening, like with the initial, so if they're initially done as a PSA and digital rectal exam and the PSA is mildly elevated, what have you, then it's totally appropriate for the primary care physician to repeat that down the line and say 6 to 12 weeks, probably, that 3 month window would be reasonable, give or take, and confirm that it's still elevated. Usually we want a confirmatory measurement because they can definitely fluctuate for other reasons. Definitely then if it is elevated persistently, then that's someone who should be referred for further assessment. With a urologist is typically the sort of entranceway in it, and mostly just because it's just kind of more numbers. Like I don't know if there's any direct referrals to radiation oncologists, but we would be the two groups that would treat prostate cancer on a primary level or on a local level, like localized level. Somebody who comes in with symptoms, then similarly, we would say is, and that's not so much that you're actually checking a PSA beat for screening. That's because they have symptoms, which anybody who has urinary symptoms then should have their PSA checked to see to make sure that it's assessed, right? But that's more somebody who's coming in symptomatic versus then just screening an asymptomatic patient, right? But I think from a standpoint of how it is going, and I can't speak for that, there's definitely it's a discussion between the patient and their family doctor whether or not they want to pursue their prostate cancer screening. We advocate that, or would suggest that those discussions do happen, and of course it's then the patient's sort of decision to make, and would hope that that happens. And we do also understand that, like, a lot of people have other complex issues, and sometimes it doesn't, it's one of those things that it doesn't maybe necessarily come up. So yeah, we would advocate that, ideally that it is a discussion that's had between the family physician and the patient to undergo regular sort of prostate cancer screening. And then if there's abnormalities to the numbers that persist on a follow-up confirmatory level, that they're referred to be seen for further diagnostic testing. And if they have someone that comes in with symptoms, that would be also assessed. Yeah.
So then let's say that happens. They get referred to yourself, obviously, like it's kind of like, okay, this is someone that we need to refer on. What next? So they come into you, and by then, you're having that conversation. Maybe you still need to run some more diagnostic tests, or maybe you're at the point where you're like, okay, no, that we are dealing with cancer. Can you just talk a little bit about like what that first appointment might look like for someone? Like, what are the next steps?
Yeah, absolutely. So initially, when someone would come in, I would obviously review what they've already had done in regards to assessments with it. And depending on sort of time frame to referral and that type of thing, I would also check their prostate at that time, ask for any symptomatic issues, of course, their other medical health, look especially, specifically at, also their age, right? And also their potential comorbidity, depending on how old they are and whether or not there's a little bit of a gestalt. If you're seeing somebody who's in their 80s with a mildly elevated PSA is a lot different than seeing somebody in their 50s with a mildly elevated PSA, because we know that there's a greater potential that a prostate cancer could impact the 50-year-old's lifespan versus the 80-year-old's. And so, and I'll get to it in a little bit, why that becomes a little bit more important, because the diagnostics with a prostate biopsy, the treatments for prostate cancer don't come without some consequences, right? So the initial assessment would be a digital rectal exam, depending on when their PSAs had looked, what they had sort of looked like up until that point. And also then gauging that with size of prostate. So if somebody comes in with a very minimally elevated PSA and a more significantly enlarged prostate that's consistent with that, that may be something that we would monitor for a bit to look for a further trend with it. On the flip side, sometimes people's PSAs may be just sort of on the cusp of normal, but not a very big prostate, and it's like, whoa, this PSA is out of keeping with the size of the gland. So nevertheless, once that decision is made, or if there's abnormality on the prostate, of course, as alluded to previously, no matter kind of what their PSA is, in most scenarios, usually warrants some further testing. So at that point, we then look at where we're sort of sitting. And the next sort of two main streams of diagnosis is prostate MRI and prostate biopsy. So prostate MRI has kind of come in as a more standardized upfront test since probably over the last 10 years. Like obviously it was in play before that in places, but in Canada, we started using it more regular, probably within that last 10-year window. The way I personally approach that is if somebody has sort of, moderate concern that there's a prostate cancer at play, so mildly elevated PSA, their digital rectal exams, benign, clinically benign, or doesn't have any real concern with it, then typically would start with an upfront prostate MRI. Okay. And the prostate MRI is a good way of sort of globally looking at the prostate. And the way it sort of works is it works on a spectrum of sort of giving you a degree of suspicion that areas of the prostate are more benign versus malignant. Okay. And so it's kind of a 5-point, scale where 1's highly unlikely, 5's highly likely. Okay. And so typically we would then look at the MRI after the fact and have a look at what it shows. And if there is suspicious areas of concern, then that needs to be confirmed with a prostate biopsy. And so more historically, before MRI was used, prostate biopsies were sort of systematic or random biopsies that they would just biopsy the different segments of the prostate, usually, the base, apex, and mid gland on both sides, and usually sort of a 12 to, plus core biopsy. Whereas now with MRI, what has been a benefit of that is that it allows the radiologists who are then doing the biopsies to target these areas of concern. And so it's probably yielded better success with our biopsies, but also then preventing people from maybe undergoing a biopsy if they don't, necessarily need one. So for instance, we'll take a patient who comes in with a mildly elevated PSA that's been persistent, prostate's a bit enlarged, so we get the MRI and it shows that they have nothing of a real clinical concern on their MRI, and their prostate volume is, 80 to 100 cc's, so 2-3 times normal. Then we're like, okay, well, this kind of jives, right? And that person, then you're like, well, we'll monitor this for a period of time clinically to see if there's change before triggering a prostate biopsy, versus the person who comes in where they have a similar mildly elevated PSA, but we see a lesion on the MRI. Then that would trigger them to go to a prostate biopsy. And that would be usually a targeted biopsy or a fusion biopsy. So that just means that they're specifically targeting the lesion. But we also ask them to then also do systematic samples of the rest of the gland as well, because MRI is pretty good at picking up, sort of, for lack of a better way of put it, but this is what I say to my patients, it's pretty good at picking up the big, the bad, the ugly. Like it's good at picking up these higher grade prostate cancers, but it's maybe not as sensitive for lower or intermediate risk prostate cancers. Now, we less likely are concerned about the lower grade prostate cancers because they'll take a longer time to develop and usually will declare themselves clinically. But it's not perfect. Let's just put it that way. It's good, but it's not perfect. So in certain instances where somebody has still ominous clinical concerns, but their MRI maybe comes back reassuring or somewhat equivocal, there still is, at times, I tell people, indication that we still need to do a prostate biopsy. Now, on the flip side, if I see somebody who comes in who's got a markedly abnormal PSA, or they have a concerning abnormality on digital rectal exam, personally, I will often advise them straight to prostate biopsy rather than avoiding the MRI. Pardon me, avoiding the MRI on an upfront basis, just because it saves them time in our system when we probably have a really high percentage chance that we know what's going on, right? So that would be the upfront way of doing it. It becomes a little bit of a challenge too, because prostate biopsies are not the most comfortable thing for people, right? It's not their favorite day getting a prostate biopsy. It's an ultrasound probe that's placed up into the rectum. The prostate's scanned with the ultrasound probe, freezing's put in, but it's all done local anesthetic. And then, 12 to, 16 plus core samples are taken out of the prostate, and that's not pleasant. There's blood in the urine, blood in the stool after, blood in the ejaculate that takes a long time to, to clear out. And the big risk of it is the risk of a more significant infection after. So rates about 2 to 5% that despite sort of oral antibiotic prophylaxis, we will see, a resistant organism and a more significant post-biopsy sepsis, usually due to a multi-drug resistant or E. coli or an ESBL, right? So that doesn't come without some potentials, and sometimes those patients, most of the time, they do fine. They come in and get the right anti-IV antibiotic, short hospital stay, but sometimes they can get really sick from it, right? And so it does sort of, you don't want to biopsy people that don't need it either. So if it was a lot more of a benign sort of thing and an easier thing for people to go through, it would be a lot easier to sort of just say, so, this is what we need to do. So MRI has really helped with that. Because in a certain subset of population, it's another way of sort of stratifying people who absolutely need this done versus people who you can maybe monitor, right? So
would you say
that's
then
where it would kind of start.
sorry to interrupt. Would you say that
No,
it's then it's the biopsy that's mostly gonna direct your or kind of like, yeah, direct your course of suggested treatment? Like it's that biopsy
absolutely.
result that
Absolutely.
that
So there
is what
is
you
there is
need.
false positives, right?
Yeah.
Yeah. So you can see that the MRIs have findings of concern and the biopsies are negative, right? So you're absolutely right. The biopsy is the diagnostic. This is what's going on.
Because
Is the
it
biopsy.
sounds like the people that you MRI and decide not to biopsy would be the ones that you're more just watching. We're just going to observe because we don't see anything that makes us think we need to put you through this. And basically, we know that this is a slow progressing disease, if you will. And so, yeah. So, did I say that right?
Yeah,
Okay.
absolutely. So
Okay.
the biopsy is what kind of says this is what we need. This is that we have a cancer here that we need to deal with, right?
Okay.
Now, with the MRI type of things, it's something that, you're right, that again, then that's somebody who, at least personally, if somebody's got a little bit of some elevated, PSA and stuff like that, that I will very rarely discharge somebody from my care after an elevated PSA clear MRI. That's somebody then I will typically monitor over the course of maybe at least a year, maybe two, to make sure that their PSA and all their kinetics and everything's going to be stable. Sometimes it comes down the line a year plus, and we've seen a little bit of climb, nothing crazy. We'll sometimes repeat an MRI in a year or two to look for change in comparison. So those are typically still people that we follow, or I personally would follow. Sometimes we see that their numbers settle out, and it's just another sort of reassuring thing, and they go back to their family doctor, and we just make recommendations to continue to monitor. And then obviously the group that goes through and ends up having a positive biopsy, then we use the grade of disease, because to speak a little bit to this whole, a little bit of a somewhat misnomer out there that prostate cancer is something that people kind of don't die of, they live with, is true in a subset of prostate cancer. But there's a big spectrum of what we deal with in prostate cancer. And I think you had alluded to in some when we were kind of chatting before is that, there's very low grade prostate cancer that we surveil. We don't actively manage. We monitor it with the idea of delayed curative intent when there's change, because we expect that, we can still avoid consequences of treatment for X number of years. And there's higher grade prostate cancer that does move fast, right? Or, faster in the whole scheme of things, right? It's not one of those cancers like other cancers out there that's like, tonight, they have to have this dealt with tonight type of thing. But the higher grade prostate cancers can be, they can be progressive, and thankfully they're not, maybe not as common, but they definitely can progress a little bit more rapidly for sure. So there is a bit of a spectrum with how people are treated based on their what their biopsy shows, but also their other sort of diagnostic things, their PSA, what their rectal exams like, potentially what their MRIs looks like.
So let's say that unfortunately, you have to have that appointment with someone, you get their biopsy results, and you have to have the conversation with them like, okay, we're dealing with cancer, and now you have to have the kind of discussion around the options like surgery, radiation, hormone therapy. Like obviously it depends on what you find from the biopsy, but can you just start, and I'm not even going to pick a fictitious person right now. I just want to talk about the different treatment options. Yeah.
Sure. So the way that I would sort of look at it is that if we have somebody who comes in who's got what I would sort of describe as favorable sort of, they've had a diagnosis of prostate cancer, but things are sort of favorable. Okay. So their PSA is not that high, or, less than 10. And so let's say that, their biopsy shows low grade, low volume prostate cancer. There's no abnormalities on their digital rectal exam. They were biopsied either because of their PSA being elevated, or it showed a little something on their MRI once we did it. But they have what is considered to be low risk prostate cancer. Those people would then generally be recommended to undergo what's called active surveillance. And the idea with the active surveillance is that we look at this low-grade prostate cancer, and typically the belief is that it's a very indolent or slow-growing type of cancer. And so the idea would be is that we monitor it, and try to then intervene with what's called delayed curative intent. So we're planning to monitor this until you get to a point where we're seeing that there's upstaging or an upgrade in this, that then we need to move forward with treatment whenever that is. And the idea behind that is that the treatments for prostate cancer can create some side effects for men who unfortunately have to go through them. And the idea is to avoid putting those guys through those side effects until they need to have the therapy done. And so that sometimes can be, multiple years, right? Other times we do see that, people will come off of the surveillance within a couple of years, either due to upstaging or due to anxiety or what have you. The surveillance is a biopsy up front, and then typically the way it was described is then you do another confirmatory biopsy again at the 12 to 18-month window, and then typically sort of the 3-year window after if everything else stayed good. You're monitoring PSAs, digital rectal exams, typically sort of on a Q6 monthly basis in that interval, with then if you see clinical concern, that would prompt further assessment. MRI then has maybe not been as well characterized within that surveillance. At least I haven't looked at the literature enough of late with it, but we do usually use MRI in there as well. So that's for the lower risk group. The rest, where we sort of get into the, sort of lower intermediate risk, and high risk population that are typically, depending again on their age demographic, for localized treatment. So they would undergo then staging imaging, typically up front with CT and bone scan, although there's a newer modality called PSMA PET scan that's probably going to replace those once it becomes a little bit more available. But a staging imaging to look for metastatic disease. In absence of us seeing that, then we would say this is curative intent localized treatment. The main standard options that are available for that would be surgical removal of the prostate or radical prostatectomy, which is still done in sort of different approaches, robotically, open procedures done in Canada, and then a few areas are doing laparoscopic prostatectomies. So, but surgery, okay? So surgical removal of the prostate is the one mainstream of therapy. And then the other one is a modality of radiation, okay? Now, Radiation, the way you sort of think of it is that there's been a lot of sort of advances with all of this, and there's nuances to that, of course, too. But the way I sort of describe it is the two main sort of types of radiation that you can get is either brachytherapy, so in pellets that are radioactive pellets that are inserted into the prostate, in people who are candidates for that, or sort of external radiation onto the prostate. And there's different sort of types of that now, so it's a little bit sub-selected, but those are the two sort of main ways that the prostate's treated with radiation, or a combination of the two. Okay. People who have higher grade biopsies will also be treated with androgen deprivation therapy. And so to just explain that a little bit is that prostate cancer is a testosterone sensitive cancer. So by removing the testosterone, you make the prostate cancer cells quiet, for lack of a better way of putting it. It doesn't get rid of the prostate cancer. It's not a definitive treatment, the hormonal therapy alone. But in the context of using it with radiation, it will control prostate cancer and make these prostate cancer cells quiet in most scenarios for in the order of years sometimes. Okay. And so they will, in people who have higher grade prostate cancer, give that androgen suppression to shrink things down, keep the prostate cancer cells quiet while they deliver the radiotherapy, and anywhere from typically a 6 to 18-month window. Sometimes in the past, historically, it had been sometimes even out to 3 years for more higher risk disease. We don't do that with prostatectomy because it's never really been shown to help. It maybe makes things look a little better initially, but it doesn't sort of improve outcomes longer term. So it's not, the hormone therapy is not used for in surgery and less, sort of outlier scenarios where there's reasons for it. And those would be the sort of standard treatments for localized prostate cancer. Now, there's other alternative therapies that are out there for sure that maybe don't have, as much, that don't have, I guess, the evidence, or still experimental, that people will see, on the internet and are being performed. But those would still be the standard ones that at least that we would typically offer for people.
What do you think would be some of the reasons why? So I just want to go into some more detail, just because a lot of people are always like, I want to know more, I want to know more. So the brachytherapy, the seed placement, this is usually done like just once. Like, would they expect to have that place? They go home the same day? Are they like put under general anesthetic, right?
Yeah, so with the modalities of the radiation, obviously, know enough about it, but not as well because I don't deliver that therapy. The
Yeah.
radiation oncologists do. But yes, the brachytherapy, you got to go down. There's some nuances to making sure that you're an appropriate candidate for that. So, they look at the size of the prostate, your pre-existing urinary symptoms and whether or not you're a good candidate for it. They have to check to make sure that the sort of pubic bone is adequate for them to site the seeds and there's no interference with that. But when you're deemed to be an appropriate candidate for that, then yes, you end up having an anesthetic, and the radioactive pellets are placed into the prostate, and they sort of have it all sort of, pre-marked out with your CT simulations and things like that. And they're placed into the prostate gland, and then those pellets emit radiotherapy to your prostate over time and provide kill effect.
And they would need to be removed, correct?
Nope,
No,
they
they
stay in
stay
there.
in there till they do their thing, and then they're not an
And
issue
then they're
anymore.
just there. So
Okay.
that's right. So if you were to, like, often you'll see a CT scan of somebody for something else, and you'll see all these little pellets down in their prostate. That's the brachytherapy
Okay.
pellets.
Whereas
So they stay in there and they
the
kind of
X,
burn.
and I've heard, sorry, what did you say at the end of that sentence there?
Yeah, so then they just stay in there. They kind of get through their half-life of their
Okay.
radiation, and then, like radiation works, eventually it kind of burns out, and then they just stay there.
And have you heard like certain symptoms, like side, like you've mentioned before, like there's not like, awesome side effects from some of these treatments. Like, um, I've heard before, like it's normal to experience like more burning or frequency with urination. Like I have to go more, it hurts to pee, things like that. Is that pretty typical, or would that just be a
Yeah,
possibility?
so with radiation so we'll just come on and just go through them kind of with what they look
Yeah.
at. So with radiotherapy, you get sort of the toxicity of the radiation,
Yeah.
right? So irritative urinary symptoms. Sometimes, obviously there's some inflammatory change within the prostate that creates those sort of, obstructive symptoms and, that dysuria that people can get. The radiation can cause a lot of overactivity at times, can also cause some bowel related symptoms. So sort of
Mhm.
similar type of stuff within the bowel, just from the acute inflammatory sort of effect of it. Has a potential to cause some narrowing to the channel or stenosis in some men with it after. And these are sort of in to some degree the urinary symptoms and some of the bowel symptoms are expected short-term side effects that we can definitely see. In a smaller set of the population, of course, you can have these that they linger on, or they can get some, some areas that will narrow down the channel, the urethra that you void out of and cause obstruction and stuff like that, or people who have issues where they can't get voiding after. But that's sort of less of the group. Okay. When you have your prostate removed, it's kind of the flip, right? So once the prostate's removed, and this is kind of where definitely we lean on our pelvic floor physiotherapists a lot. The prostate provides a very good control mechanism for the bladder, right? We know that it obstructs men when they get old, even if it's benign and all that stuff. And so when you remove the prostate, and for everybody out there who's not familiar, the prostate, you void and you pee right through your prostate. Okay. It's part of the initial part of the outflow of the bladder in a male. And so you pee right through the prostate. So the prostate is removed off the bladder neck and then the urethra or the channel that below that. And once it's removed, you've removed this sort of what's called, there's a bladder neck, sort of the bladder neck function provides urinary control, but also smooth muscle throughout the prostate. And then the prostate, sort of that prostatic urethra is a good control mechanism for the bladder. So once that's removed, then after your prostate's been removed, you're relying on your pelvic floor for your urinary control. And that definitely takes time. And so one of the biggest things that after prostatectomy is that then people initially are more significantly incontinent. Okay. And we do see improvement with that. And that's where a lot of the pelvic floor physio comes in. But we do know that, out to the sort of 6 to 12 month window and out to sort of 12 months, that there still is 20% of the people who undergo prostatectomy that don't get their urinary control back, and it's more significant incontinence that want something more done about it. So that's the sort of one thing post prostatectomy. And then the other sort of long-term thing with both of these treatments is how it impacts people's erectile function. So nerves that supply the erection run right on the outside of the prostate. They can be impacted by both of these treatments significantly. With surgery, we do nerve sparing procedures and in most cases try to reflect the nerves off the prostate. But even in doing so, it still has a real significant impact on people's erections that, a good majority of them need medical intervention afterwards to achieve an erection after. Radiation is similar. Brachytherapy's outcomes are probably a little bit better with that, or they are a little bit better with that, with improving sexual function. But those are some of the side effects that people can have after their prostate is treated, right, over the long term. And so that does sort of circle back when people get a little bit, when we say, I talk to some people who have this low grade disease, who we say, well, we've diagnosed this cancer, but we're going to monitor. And they're like, what,
Mhm.
what are you saying, right? And so the idea is to, even if you can spare some of these men those symptoms for 5, 7 years, then that's obviously good, right? So that's why this active surveillance has been something that's been a bigger thing in the probably, it's been 20 plus whatever, it's been years. Like it's not a new thing, but it's why it's been developed, right?
So, how often, when you're having that conversation with your patients, does it come down to a choice, between radiation and surgery? I mean, that they have a choice, or would it be more often that, okay, based on this, we need to do this, or do you know what I'm asking?
Yeah, absolutely. So I would have to say that it's kind of at the end of the day, they don't always have a choice, but
Yes.
there's certain people who are definitely better for one versus t'other. Okay. So obviously going through a surgery is harder on people who are, or who are older. And to kind of go through all of it, there's certain reasons why people, you will maybe advise them to have one or other. So let's just look at certain other things in people's health. So if somebody has inflammatory bowel disease, Crohn's, ulcerative colitis, they are then essentially not a radiation candidate, right? Because it can impact the bowel. So those people, then, or if somebody has more significant comorbidity that, a surgery is going to potentially impact them, then they go, obviously it's recommended that they have, a less invasive approach, right? Prostates that people who have a hard time already, who have a lot of obstructive urinary symptoms, have difficulty emptying their bladder, then they may be better suited with prostatectomy, right? Because then they're going to have more troubles after radiation with obstruction, and it's much harder to manage, urinary obstruction after a prostate's been radiated than before. So those are maybe some of those things. Oftentimes, we'll always also look that younger men typically will benefit more from surgery than radiation, and that's you may acknowledging bias. I'm a surgeon and a urologist, so I'm acknowledging bias here. But just because you get a bit of a better idea with what the actual pathology is, the prostate comes out, so you know exactly what you're dealing with. The whole gland being looked at. We always usually remove the lymph nodes and look at them. But I think the bigger thing is that it's way easier. You can from a standpoint, if there is a local recurrence after you've removed the prostate, okay, you can get further radiation to the pelvis to salvage if there's local recurrence or pelvic recurrences with radiation to the pelvis after the prostate's been removed. It's becomes much more complicated to remove a prostate that's been radiated if there's a local recurrence, and then often there's not any more radiation that can be done. And so in a younger man who's in his 50s, and has those compared to somebody who's in their 70s, if you have a local recurrence after that's been, then it's obviously is advantageous to then have another approach to try and provide curative intent. If somebody in their 70s has a recurrence of prostate cancer afterwards, we can probably still, in a lot of cases, control that with the hormonal manipulation or the androgen deprivation therapy long enough that it may not impact their lifespan still, but they've already lived those 20 years. So maybe we're trying to get another 15 years with, starting with hormone therapy. There's been a lot of advances with further intensification with that. There's chemotherapies, immunotherapies, and, you can still control disease for a long period of time for prostate cancer in most people. And so that still in a 70-year-old may not impact their lifespan to any degree, but in a 50-year-old who hasn't lived those 20 years, we may still impact their longevity. So having an alternative form of treatment to offer with a local recurrence is probably more beneficial in a younger patient than an older patient, just because of that. So that's one of the age reasons to do it as well. But at the end of the day, when I look at this and I tell sort of all my patients, and this is my personal thing, is that I go through all of this with them and I say, like, as opposed to other things that we treat, that after we've treated them, you kind of don't have much symptoms from it. This one has some consequences no matter what you have done. And in a lot of cases, if there's not a specific reason to do one versus t'other, it's very much, what their sort of preference is and what they feel the most comfortable with. Because, there is going to be some recovery to be had with, no matter what modality you go through, unfortunately.
I listen to
If
this.
that makes sense.
I listen to this and I think there's a lot of factors that go into this because it'll depend on whether you have physios in the area you work and also there's barriers to seeing physios for the most part because a lot of us work in private practice. So unfortunately, it's not a publicly provided service, but I'm curious to know how often referrals go to physios before like surgery or radiation. Like, I'm just curious a little bit. And again, I'm not asking you to speak for everybody, but like, is that something that you do in your practice, is like
Yeah,
send people
we
before?
absolutely. Yeah, absolutely. So we've always had since I've been here, had a very good continence nurse, and now that's, was involved with that. But we now actually have, and it's been a little bit, it depends a bit on the volume that the people have seen, but we had a physio that worked in our office once a week. And all of our patients, when they're booked for surgery,
Mhm.
then get an appointment with that physio if they wish to do it. If they're from out of town, we have good relationships with our powerful physiotherapists in town, and as well as the other centers that we treat. And so every patient, when they get a radical prostatectomy, we book a radical prostatectomy through our office, unless they decline it, is offered to see a pelvic floor physiotherapist.
Which is great because I listen to you and think like so much of what I take out of working in this area for a while is just how little we learn about our quote unquote private parts and just even how they
Yeah.
work. And I always think of them like valves that work related to pressure, and a lot of things affect those valves and affect the way our pelvic floor works. For example, like a lot of men develop a lot of habits around pushing their pee out really hard when, for example, they just have maybe prostate enlargement or they're hurrying, and it creates a lot of tension in the pelvic floor and it becomes a habit, really. And
Yeah.
so some of their habits create some of their output, if you will, their output issues. But I also listen to so many people that'll have a lot of stress around something like cancer, and we know just like stress increases sympathetic nervous system like upregulation, which creates more muscle tension. And I listen to you talk, and I think like sometimes that's one takeaway that a lot of men have after their radiation or surgery is just like, oh, I wish I kind of would have learned about this before so that I kind of knew how to work my if my top valve is getting removed, I know how to use my bottom valve, and I just know things that I can work right after my radiation on or what have you, because I think a lot of times men take away, this is something I need to do after my surgery. But sometimes it takes weeks or months to be comfortable going to see someone to say, I'm in a diaper. And it's so often they're like, oh my gosh, I'm so embarrassed. I have to go see this female practitioner and I'm wearing a diaper
Yeah.
and I can't get an erection and I don't know how to talk about this. And I think sometimes building that rapport before so that they feel comfortable asking about things like, how do I work this clamp for my penis? Like I've heard that I've seen online, or my urologist told me I could
Yeah.
use this penis clamp, but it takes a long time to ask the questions. Or I've heard about a pump, like a penile pump to help me with my erections, but they
Yeah.
just don't like to ask the questions. And so I hear a lot of times, I'm like, how do I help get the message out that if you come before, maybe you feel a little bit more hopeful about your recovery. Yeah.
Yeah, I definitely think so. And working on it before, like, because men in a lot of cases have never had to engage their pelvic floor
Yeah.
like I've had, right? Like you just haven't had to do it. And so getting that before, when you're obviously haven't gone through the surgery, things are going to be more comfortable doing it too, because of course, after you've had a pelvic surgery, it's maybe not the most comfortable to be doing the exercise, or sometimes for some people. It would be nicer to get them in even earlier, but usually it's when so they're not in there much more than sort of that 6+ week window, give or take, depending on their disease characteristics. But at least it's getting the idea started. But it's also just another voice to kind of reinforce that there's going to be some recovery to be
Mhm.
had too. You have to be, because, it's like anything, you don't know what you have going on until that's there, right? And it's surprising that, when they have leakage or they have issues where they, are having troubles voiding, that it's obviously way worse when you're going through it than when you're trying to sort of think about this expectation down the line, when you have another diagnosis in front of you that you maybe are more worried about or should be more worried about, right? So definitely, I think it is helpful getting them in there sooner. I think that from a standpoint as a urologist, too, in discussing with the people afterwards, is being, it's always one of those things that, with removing the prostate, even though you've had maybe you have really good oncological, outcome afterwards, but everybody has some recovery to be had, and it's, there's obviously a varying degree for different people, but I think we're becoming a little bit more better that, we're asking them about it rather than just kind of like, well, if they don't say anything, then, we'll leave it be and we'll follow up next or whatever. And we're hopefully as a group saying we are acknowledging that people, you're going to have these recovery points that you need to get through, and that there's a potential that you may be one of those that don't get to that point at say 12 months post surgery, or you may be one of those people after radiation that's going to have a lot of irritative symptoms and that type of stuff, and trying to address it, trying to provide expectation for people, and also then providing them with options to how to try and deal with it to the best that they can. And I definitely do try to be as forthcoming going in that there's going to be changes. This is going to be different now after this, but we have a high risk prostate cancer that's, a problem that needs to be dealt with. And try and provide expectations going in, but afterwards try not to sort of hide away from somebody who's maybe not had a good functional outcome, and trying to say, listen, like, we know this going in, there is options, there's secondary surgical options to try and help with your incontinence. Are we at this point? How can we support you? What's the degree of bother? And, and then some guys, like you suggested, some of them are like, things are pretty good until I go and hit the golf course. And then it just, that movement, creates the problem. So what about these penile clamps or these cuffs? And, thankfully we've had really good trained continence nurses that have worked in our office who will do fittings for people and show them the products and try and help them out with that. One of our urologists does all of our sort of, prosthetics and implants, and has trained our staff with them, and is pretty good at looking at that, doing a lot of, for the erection side of things, doing a lot of sort of pre-habilitation, not just with our, with a standard sort of starting people on, our PD-5 inhibitors or like the Cialis, Viagra, stuff like that, to try and augment recovery, but guys who are, getting them using vacuum pumps to prevent shortening and atrophy in advance of potentially getting a prosthetic. So we're just trying to, at least personally, I'm trying not to shy away from those discussions, at least with the guys post prostate cancer treatment. Just hoping that they won't bring it up, because sometimes they're longer conversations, right?
Yes.
But the more sort of times that you can have these discussions with people before, after, during, then I think it makes them open up a little bit more, and at the end only just helps them. And thankfully in BC, we do have a pretty good sort of prostate cancer support network that allows people to sort of get a better grasp on where things are going. But no doubt there's guys who do great after this, both cancer wise and functional wise, and there's guys who have more troubles than others, and it's very hard to predict who's going to be who
Yeah. Well,
sometimes.
I, yeah, no, you've answered so many great questions that I think will kind of like transition nicely to the next episode that we'll talk more about like physiotherapy specifically. But anything, Jeff, that you feel like is important to get across that I didn't ask you? Like I said, I feel like you've covered everything that most people have questions about, but anything like
Yeah, no,
major that you're
I
like,
don't
we
think
didn't
so.
talk
Like,
about this. No.
no, not specifically. We kind of, like you said, you sort of set it up where we sort of start to finish with it. I would just sort of say that it's from a standpoint of prostate cancer, it's a very common thing. Especially, everybody will know somebody who's had prostate cancer. And it's important that you do get screened for it. And on the flip side of it, people who go through therapy, things are always advancing. And although this, as opposed to treating other malignancies, does have some longer term consequences, there is hopefully some strategies that are getting better and better to try and help people, their quality of life with that after the fact, and still feel that there is quality to their life that we can, after that we can help them with these issues that they inevitably, some of them have, and maybe don't want to bring up. So I think it's going to be an ongoing thing. And I definitely, with our role, speaking to yourself with the pelvic floor physiotherapy, it is paramount with our group. We've tried our best to get people in to see them, because you're right. There is, to be honest with you, like, I can tell them to do these exercises, but we know evidence that if they go in and see you guys and they're shown how to do them properly and they have somebody engaging with them, that it just works better. And we don't have the training in that, right?
Well, it's interesting.
So
You can see, like, even just from something that you watch all the time, I can watch people, even if I'm not actually doing like a digital exam or if I'm not actually watching their perineum or anything. Sometimes you just start to learn, you're just like, I can tell you're tightening your butthole. Like, don't tighten your butthole, tighten the front. But exactly. And we have lots of research that says that verbal education alone quite often isn't enough. And it's, again, when they're
yeah,
not muscles that you ever think about, it can be really hard to start thinking about them. And we have all sorts of little cues or tricks to be able to find the right muscles. But again, another plug for the
yeah, and
before
especially
prehab,
yeah,
right?
totally, and especially in men who've never had to recruit their pelvic floor.
Yeah.
Just never had to use those muscles because they've had a prostate there, and it's just, more troubles getting it out than keeping it in a lot of cases. So
Yeah.
yeah, I think it's definitely we've that's been something that we've been trying to do more of, and definitely have increased our support staff to try and, at least in our office, to try and provide that support. So, we knew how have sort of two, sort of our continence nurse does also our urodynamics, but we have another nurse in the office. They're trained in do all of our post-op prosthetic placement follow-ups, and are willing to put in time, plus our local pelvic floor physiotherapist, and one that will comes and works in our office. So it's hopefully it's been helpful. Obviously, the patients would have a different idea with that, but hopefully it's been, because we do understand that these treatments do ultimately have impact on people. It's not lost on us that they do.
That's great. Well, thank you so much for your time, Jeff. I appreciate it.